Welcome back. This is Dr. Rockhold with the second of three segments on opioid analgesics. With this segment, we'll examine in detail the strong agonists, agents which are full agonists at opioid receptors. The chemical grouping of these depends on whether the drug came directly from opium, as in the case of morphine, whether it is derived from the natural drug structure, semi-synthetic, and an example is hydromorphone, or whether the drug is from a completely different chemical structure, a synthetic opioid. Meperidine and fentanyl are two prominent examples of this type. As mentioned earlier, a natural component of opium, thebaine, is the starting compound for several important semi-synthetic opioids, including oxycodone, oxymorphone, hydromorphone, the antagonist naloxone, and the mixed agonist-antagonist buprenorphine, and we'll talk about these later. The prototype opioid is morphine, usually given as morphine sulfate. It can be administered through several routes: oral, injectable. It can also be given rectally by a suppository. It's important to recognize the route of administration that's used because morphine is metabolized avidly by hepatic enzymes. Thus, the oral dose is some 6 times greater than that needed to produce an equivalent analgesic effect when given parenterally. The rectal administration also largely avoids first-pass hepatic degradation. An active metabolite of morphine is morphine 6-beta-glucuronide, which is formed in the liver. It has somewhat different receptor binding profiles than does morphine, and it has different pharmacokinetics. We believe that it influences the body's response to oral morphine, the analgesic response in particular, to some degree, but we don't know exactly how much at the present time. You'll remember heroin as diacetyl morphine. It is a major drug of abuse. An example of raw heroin is shown in the lower part of the slide. It is a DEA, Drug Enforcement Agency, Schedule I agent. Thus, it cannot be used therapeutically. We're going to talk in greater detail about controlled drugs and drug scheduling towards the latter part of this course. It's important to recognize and remember heroin as a prodrug. It must be deacetylated to produce the active compound morphine. The greater lipid solubility of diacetyl morphine means that it can penetrate the brain much more rapidly than does morphine, and this generates a much more intense euphoric response, hence leading to its particular abuse liability. Oxycodone, or OxyContin, is a semi-synthetic full agonist at the mu-opioid receptor. It's typically marketed as a delayed-release tablet for severe chronic cancer pain, but it has developed a reputation as a frequently abused agent. This delayed-release feature has important consequences. First, it introduces the pharmaceutical practice of abuse deterrent formulation, in which attempts are made to create delivery methods that make it more difficult to maximize the recreational impact of a drug while still retaining the clinical utility. In the case of oxycodone, the tablets are manufactured so that if a tablet is orally ingested, the active drug is released gradually as planned. However, if crushed and dissolved, the entire dose is available for receptor stimulation at one time, and this has proved to be lethal in many cases, as shown by the Clarion Ledger headline back from 2001. Chemically, oxycodone is synthesized from thebaine. In the human body, some oxycodone is metabolized to another active opioid, oxymorphone, which contributes to the analgesia, but must be recognized when considering analysis of urine drug screening results. Hydromorphone is a semi-synthetic full agonist at the mu-opioid receptor. While an excellent analgesic, it has gained a reputation as having a relatively high abuse liability. For example, At equi-analgesic doses, hydromorphone is about 10 times more potent than is morphine in self-reported euphoric effects. Thus, you see things on the web like give hydromorphone, make a friend for life. Hydrocodone is another semisynthetic full agonist at the mu-opioid receptor. It's used primarily for mild to moderate analgesia, and it's important to recognize that it is only available in oral formulations, almost always in terms of combinations with a nonsteroidal anti-inflammatory agent, acetaminophen, or aspirin, as noted by the trade names shown here. Recently, it's been marketed as controlled release substances. Hisingla ER and Zohydro ER are two of those controlled release compounds. Even in combination with non-opioid analgesics, however, because it is an opioid, all of the preparations noted here are DEA Schedule 2. Methadone, or dolafine, is available as a mixed enantiomer. Levomethadone, the L enantiomer, is a synthetic full agonist at the mu-opioid receptor, and dextromethadone, the S enantiomer, is an antagonist at the excitatory glutamate NMDA receptor. We believe that most of the clinical effects of methadone are due to the mu-opioid receptor agonist activity. We're not entirely sure what the NMDA receptor antagonist properties contribute. Methadone is more slowly metabolized than is morphine, and it also dissociates from the mu-opioid receptor at a significantly longer period of time than does morphine. It's usually given only once a day as an oral solution. And while it has excellent analgesic actions, it's used to largely manage opioid use disorder, either to maintain patients and prevent withdrawal, the maintenance therapy aspect, or in management of acute detoxification. Its subjective euphoric actions tend to be relatively less intense than those of morphine, particularly after oral administration, so its abuse liability is considered to be less than that of other full mu-opioid receptor agonists. However, it's important to recognize that abuse liability for methadone is not zero, and illicit use of methadone is significant. It has characteristic opioid adverse effects, but it can also prolong the cardiac QT interval, which may lead to ventricular arrhythmias and death. Fentanyl is a drug that's very much in the news these days, both as a drug of abuse in itself, but also as an unrecognized adulterant that can be mixed in with other drugs of abuse. Think of it as swift, short, and strong. It's a synthetic full mu-opioid receptor agonist. Its actions take effect within 1 or 2 minutes following IV injection. It's swift, but it maintains its analgesic effect for only 30 to 60 minutes. It's short. It's roughly 100 times more potent. It's stronger than is morphine. So a standard analgesic dose of fentanyl is 0.1 milligrams versus 10 milligrams of morphine if given intravenously. It has a high first-pass hepatic metabolism, and it can be obtained in several formulations. For example, Actique is a flavored lozenge on a stick. It's effectively a lollipop that can be used for oral administration. Duragesic is a transderm patch that delivers fentanyl over 18 to 24 hours. It can be given IV. There are buccal tablets, there's a nasal spray, there's a sublingual film, lots of different formulations. We need to recognize also that fentanyl is the prototype of numerous similar synthetic compounds, some of which are available for use, for example, sufentanil. Others are illicitly produced. More about that in a moment. This slide is a visual comparison of the toxicity of fentanyl and heroin. It shows the approximate amounts of each drug that can be expected to cause lethality in an adult. Fentanyl requires about 3 milligrams to kill, whereas heroin usually requires about 10 times that, 30 milligrams. Fentanyl is also about 100 times more potent than is morphine. And finally, fentanyl has a higher affinity for the mu-opioid receptor than does morphine. So the combination of the potency and the affinity at the receptor contribute to the increased likelihood of toxicity for fentanyl. And we know that fentanyl, or perhaps a similar agent like carfentanil, is believed to have been aerosolized and used to incapacitate terrorists in 2002 in a mass hostage situation in Russia. It worked, but it also killed several dozen hostages before the antidote, naloxone, could be administered. I mentioned carfentanil, or Wildnil, in the last slide. Carfentanil is a fentanyl derivative, and it was developed for and used for large animal, literally elephant, veterinary anesthesia. The comparison here is the rough lethal dose of carfentanil, fentanyl, and heroin. And in doses as small as 20 micrograms, carfentanil can produce lethality. Both fentanyl, some cases carfentanil, and then other designer analogs such as U-4770 are gaining significant entry into the illicit opioid drug supply. Obviously, even small amounts of contamination of something like carfentanil into another opioid or another abused drug will dramatically and unexpectedly, at least to the user, increase lethality. The last strong agonist that we'll talk about is meperidine, or Demerol. Meperidine is a synthetic full mu-opioid receptor agonist and has excellent oral bioavailability. It has proven to be a very good analgesic, but you need to remember that it has an active metabolite, normeperidine. Normeperidine has a long half-life, and it has a tendency to accumulate if meperidine is given over a period of several days, such as might occur if a patient is on a meperidol infusion following a major surgical event. The accumulation of normeperidine under those circumstances can cause neurotoxicity, including tremors that may lead to convulsions. Thus, meperidine should not be used ever for managing chronic pain. It can lead to the serotonin syndrome, and it should never be administered with an MAO inhibitor or another drug that is known to increase synaptic serotonin concentrations. Primarily, its use is in analgesia, and it can also be used to help control post-anesthetic shivering. It has something of a reputation as an opioid that causes less meiosis than do others, possibly because it has some antimuscarinic actions. This has led to abuse by providers. The opioid-induced meiosis that other opioids would be obvious to other professionals, not so much with meperidine. And finally, it's in the same general chemical class as another mu-opioid receptor agonist used for diarrhea, loperamide, and we'll discuss this in the next and third segment of this series. Thanks for your attention.